What I will try to cover over the coming few minutes, 20 minutes or so, is some technical aspects about adsorption, and specifically clinically relevant technical aspects. Also, I'll go over indications, I'll go over the evidence, what are the adverse events that we have to watch for, and then hopefully we can come up with a few conclusions together. And I have a confession, because it's sort of the last session of the day. This topic has been covered by outstanding speakers earlier in the day, so there will be some repetitions. All right. So one line about what adsorption is all about. Adsorption, in very simple words, is just a mechanism of solute removal. As we all know, the main or the major mechanisms for solute removal is convection and diffusion. Both are membrane-based. We remove solutes across a membrane. In the case of diffusion, it happens down a concentration gradient. In the case of convection, it happens down pressure gradient. Adsorption, on the other hand, is a little bit different. So what happens in adsorption is we clear solutes by basically direct binding. You would obviously need an extracorporeal circuit. Blood would circulate into the sorbent cartridge and gets directly exposed to the sorbent material, and then the solutes that you're trying to clear gets cleared. Now, this comes with a lot of positive things that we mentioned throughout the day. First of all, the issue of the large surface area. The design gives us the positive part of having very large surface area for clearance, and the different pore sizes of those sorbent materials also allows us to have clearance of different molecular weights. Now, this does not come without a price. The issue of biocompatibility is a very important issue in the world of adsorption because of the direct contact of the blood components to the sorbent material. We oftentimes, we do have to sort of keep in mind the possibility of bioincompatibility. Okay, so to deal with this issue, the first solution is very simple. We use coating. If the material is causing reaction, we simply cover it. But as we all can imagine, this can lead to reduction in the efficiency of the sorbent material. The other option is, this has been covered in very full details, so I'm just going to focus on the part of how we use CPFA to avoid bioincompatibility. Basically, what you're trying to do is you're separating the blood cell components from the plasma, and then only plasma gets exposed to the sorbent material, and this way we're sort of avoiding the possibility of bioincompatibility. All right. Another, in my opinion, clinically relevant technical aspect is the issue of saturation, and this has also been covered in the morning with Professor Clark. So in this study by a group from China, they looked into what's the clearance over time in patients with paraquat poisoning. And then what they have noted is the most clearance you get is basically within the first hour of therapy. Beyond 1 hour, clearance dramatically drops. So in other words, if you're trying to get effective clearance by adsorption, what you want to think about is more frequent therapy rather than prolonging your session of therapy. So this way you're sort of getting another peak. All right. Another important or clinically relevant aspect is the effect of initial level. In the same study by the same group, they divided their patients into 3 groups: those with the lowest level of paraquat, and those with the highest level, and obviously the group in the middle. Over time, only the group that had the highest initial level had meaningful clearance. And that sort of makes sense. If you're trying to clear a solute, the higher it is at the beginning, the more clearance you will get. And this becomes clinically relevant when we talk about the trials, which I will do a little bit later. Okay, as far as clinical applications, poisoning has always sort of been the agreed upon indication. Over the years, it's been adsorption mainly has been used for poisoning. Over the years, the uses has expanded to involve acute conditions and chronic conditions and other conditions. Acute typically would be the focus of our lecture and the whole day, and that would be sepsis, pancreatitis, cardiac surgery, etc. Chronic conditions is basically chronic dialysis complications. And other indications would be stuff like autoimmune diseases. Okay, so the focus will be acute conditions. And this slide has been shown so many times today, it almost feels that if you don't have it, it's like a requirement of a presentation. Anyways, this is for a reason, because it beautifully shows us the idea or the theory of why we use extracorporeal therapy in patients, critically ill patients in general, and adsorption as well. The thought of the peaks, we're trying to sort of break the peaks and restore a balanced immune system to avoid the damage that comes along with the immune system overactivation. Okay, this also has been shown before, but it also shows beautifully the wide range of molecular weights that we are trying to remove in critically ill patients. Okay. Now, with the wide range molecular weights that we're trying to remove over the years, a lot of devices has been developed, and that's no surprise. Polymyxin was one of the earliest, and we've talked about it very thoroughly and beautifully by our previous speakers. What I will try to go over is some of the trials in the context of acute conditions, firstly in sepsis. I will not go over the polymyxin trials because we've already done this. And we will move on to the trials involving the other cartridges. Cytosorb, in this report by the group from Germany back in 2013, 43 patients with sepsis and acute lung injury were treated for up to 7 days. And what they noted was reduction in inflammatory mediators level. However, this was not associated with mortality, difference in mortality. And honestly, with the sizes of these studies that I will go over, I'm not sure even we can comment on mortality with the sizes of the studies that we will discuss. This was followed by another study by the same group in the same, more or less the same context, the same prescription, and it was also associated, it also showed evidence of decrease in inflammatory mediators. And again, mortality was not really better in the treatment group compared to controls. If anything, mortality was higher in the treatment group. And there are some sort of thoughts about why this was the case. Renal replacement therapy requirement was higher in the treatment group. So this may simply reflect that this group was a sicker population. So that's a possibility. And all in all, the study was not really powered to examine mortality. This has led to the Cytosorb registry that we also heard about earlier in the course. So basically, every patient who gets treated with Cytosorb, they get reported to this registry. And so far, according to their most recent report, 135 patients with sepsis have been treated. And it seems to be therapy with Cytosorb is not associated with side effects. It is associated with improvement in inflammatory mediators. But mortality also, observed mortality is better than predicted mortality. Moving on to different type of cartridges, but also in the context of sepsis. Here, the HA330 cartridges studied by a group from China. In septic patients, 44 patients, therapy is typically given 2 hours for 3 days. Also, there was reduction in IL-6, IL-8, and there was improvement of hemodynamics. There's improvement of SOFA score, but not so much mortality. Same group, similar context, similar device, the same device, also improvement of inflammatory mediators, and this time it was also associated with improvement of not only hemodynamics, but also mortality, and that includes 28-day mortality, ICU mortality, and also improvement in SOFA score. Okay, moving on to another acute condition, but different context, that is cardiac surgery. So Cytosorb was the most studied in the context of cardiac surgery. In this report by Bernardi et al. In 2016, 37 patients were treated with Cytosorb. Those patients were elective cardiac surgery patients. They did not have any sort of acute infection. And what was noted in this cohort is that there was no reduction in inflammatory mediators, which was sort of not along the line of the previous reports. And some of the thoughts on why this could be the case is the fact that, as we said, those are elective cardiac surgery patients. So their level of cytokines to start was not really sky high. This brings us back to the importance of the initial level. So if you're starting off with low cytokine level, the reduction in inflammatory mediators using this type of therapy may not be high. This was followed by another study in the context of cardiac surgery, but this time the patients had infective endocarditis. So as we can all imagine, with an active infection, their cytokines level probably was sky high. And this one was more consistent with earlier reports, where there was reduction of IL-6 and IL-8 and improvement of hemodynamics. And importantly, all these studies were not really associated with adverse events. The treatment time in this case was more or less on the lower side, but as we have listed there, IL-6 level was really high, which can explain the improvement in the study. Okay. In this case, it was a study with a cohort of heart transplant patients. And only one cycle of cytosorb therapy was applied. And it looks like it did result in improvement of hemodynamics, especially at 48 hours point, along with improvement of vasopressor requirements, reduction in vasopressor requirements. This was also associated with improvement of renal replacement therapy requirement after the surgery, as well as 30-day mortality. And importantly, there was no increased risk of bleeding in the treated group versus the controls. And it was also associated with reduction in the inflammatory mediators as well. Okay, this is the same registry, it's not another one. Basically, also cardiac surgery patients are being reported, and it seems that the observed mortality in this cohort is also lower than the predicted. Okay, now I realize this slide is impossible to read because I have no plan to read it. This is just to show you that there are more studies that discuss the different cartridges that we just went over than what I have went over. But something to keep in mind, these studies are all more or less, although we have good number of studies, they're small, they're often single center, they're not standardized. For example, the prescription, whether the patient received 1 session versus 2 or 1 hour versus 2, or whether they measured endotoxin level before the therapy or not. So even though we have good number of studies, we have to interpret the results with caution. Okay, so bottom line from the studies, it seems that there are no side effects associated with adsorption cartridges in general or the technique itself. It is associated with reduction in inflammatory mediators. There is improvement of hemodynamics, but the data on mortality is not consistent. So that was sort of where we are with the evidence. So let's talk about what are the pitfalls or what are the things to watch for if you think that you want to apply this type of therapy in whichever context you're thinking. So the adverse events, very simple way of thinking about it is extracorporeal circuit related, because you would need this to apply the therapy, and that comes along with its own risk of clotting, bleeding, catheter complications. But there are things that are specific to adsorption, like unpredictable losses of molecules. We don't really know what gets absorbed, like low platelets and low white cell count, as everyone has discussed earlier, and also drug removal. And that's the one I want to spend 1 or 2 minutes on. Drug removal was studied back by our group in 2002 using Betasorb back then. They tested the removal of 14 different medications, including antibiotics. And antibiotics, honestly, quite honestly, are the most important ones that we're all worried about, because as we all know, those are critically ill patients. They're often septic. The only proven therapy is antibiotics. So if you're not sure what you're doing with the antibiotic, or if you need to top the dose, or how much is being cleared, that is a very important concern. And they did show that not so much for aminoglycoside on the right, but more for vancomycin. If we look at vancomycin, over the different time points, there was significant clearance of vancomycin. And any nephrologist in this room can tell you how much we prescribe vancomycin for our patients, sometimes too often. Another class of medications on the list that also was observed to get cleared is CNI, and that's important in the context of glomerulonephritis, which is another potential application for this type of therapy, and antiepileptic medications. So bottom line, if you're thinking about using adsorption, we have to be careful to balance the risk and benefit, and we have to apply drug level monitoring when possible. Okay, with that, I will conclude. Adsorption seems to be a very promising technique, despite all what we went through. Biocompatibility and low toxicity are absolutely important. For me, the biggest struggle that I always sort of face is we all agree it does decrease inflammatory mediators, but the question is how much of the reduction in the inflammatory mediators result in clinical outcomes? And so I guess it's fair to say we do need larger trials to sort of answer this question and maybe use a different endpoints and to decide which context, which patient, when to start, how long to continue, and how to judge therapy. With that, my presentation comes to an end. Thank you.